And we have folks that are still coming in. I'll keep clicking admit as fast as I can while we go ahead and get started.
All right. So good afternoon, everyone. Thank you all for joining us today. First, I would like to go over our agenda. So first, I'm sorry. Okay, so first I will turn it over to Dr. Stills and he will introduce our speakers today. And then we will have 3 rounds of questions, and I will be asking these questions to our speakers. And at the end, of course, we will have our Q&A. And if you have any questions at that time, you may drop them in the chat. And if you have any questions during the session, feel free to drop them in the chat or raise your hand. So now I will turn it over to Dr. Stills so he can introduce our speakers today. Thank you.
Thank you. I'm going to read just their shortened bios because both of these terrific women today have very extensive bio sketches that cover years of impact in this field. Dr. Keisha Gaither is a double board certified physician in OBGYN and maternal fetal medicine and holds a master's degree in public health, a perinatal consultant and women's health expert. Gaither's expertise is grounded in both research and her professional experience in caring for women with multiple medical, surgical, and fetal conditions in pregnancy. In her current role, Dr. Gaither serves as the Director of Perinatal Services and Director of Maternal Fetal Medicine for New York City Health Plus Hospitals, Lincoln in the Bronx. Dr. Gaither additionally is an Associate Professor of Clinical Obstetrics and Gynecology with Cornell Wheel Medicine. Our second speaker is Jasmine Getro-Moore, a professional health equity leader, consultant, and academic scholar pursuing a PhD in educational leadership and cultural foundations at the University of North Carolina, Greensboro. Jasmine's professional background examines the implications of structural inequality on minoritized people. She holds a master's degree in public administration and a bachelor's of science in public health with a concentration in community health education. Jasmine leverages structural racism as an analytical method for interpreting systemic inequalities within the social determinants of health model. The social determinants of health are conditions in the environment where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes. Furthermore, Jasmine is the co-founder and executive director of RJ Squared LLC, a reproductive justice technical assistant consulting firm that centers on reproductive justice framework outlined by Sister Song Women of Color Reproductive Justice Collective. I'll turn things back over to Tamika Sanders, who is facilitating today. Tamika is our health equity intern at the Research Policy and Impact Center, and she's also a second-year candidate getting ready to graduate with a master's in public health from the University of North Carolina, Greensboro. Tamika?
Thank you so much for that, Dr. Stills. So first, our first round of questions will be about problem statement and current issues of Black maternal health. So our first question is, why is the maternal mortality rate for Black women significantly higher than that of white women globally? And I can use a statistic. So study shows that Black women are 3 to 4 times more likely to die from complications during childbirth than white women. And if you need me to repeat the question, ladies, please let me know.
You want me to go first?
That's fine.
Okay. This is a multifactorial, multifaceted issue. So let's start from some medical perspective. One of the things that is seen is that, as you said, Black women have significantly higher adverse perinatal outcomes than other ethnicities. And it doesn't matter at what socioeconomic strata they are in. They can be exceedingly wealthy, as we've seen with the outcomes of Serena Williams, or they can be very poor. Their educational status doesn't matter. You still see the same things. So let's talk about that from an epigenetic standpoint. One of the things that happens, and it is called an epigenetic factor, is you have external issues impacting your physiologic function, okay? If you are consistently being exposed to disparities socially, economically, politically, these tend to cause stress. Stress causes an increase in a hormone in the body called cortisol. Cortisol is the stress hormone. It's the fight or flight hormone. You know, if you get into an emergent situation and you need to run, that cortisol helps you to have the muscular momentum to get out of there. However, if the cortisol is constantly being excreted in your body on a continual basis, it causes a number of adverse things that can happen to you. Cortisol increases your blood pressure. Cortisol diminishes your immunologic function. Cortisol increases your risk, if your immunologic function is diminished, it increases your risk of infection. Cortisol impairs the way the vasculature in your body functions. So when we start looking at particular outcomes among Black women, the top things that impact your perinatal outcomes are hypertensive issues with preeclampsia and strokes and so forth, hemorrhage, okay, preterm delivery. Those are the three top things which will take you out. I should also add cardiovascular issues as well. So if you've gotten this excess cortisol moving around in your body, it's going to cause these adverse physiologic changes. And so the top four things that I've mentioned, hypertensive disorders, cardiovascular disorders, infections and preterm delivery, because preterm delivery, it has an infectious component to it, as well as hemorrhage. These are the things that are going to knock you out. So if we're just talking about the increased stress, that's one factor. But then you need to take it to a higher level. Why are we seeing such an increase in adverse outcomes just based on stress? Well, you know, does the mother have insurance? Does the mother have access to adequate prenatal care? Does the mother have access to adequate nutrition? Is there a facility that is near the mother for her to get to? Is the mother living in a place that has adequate and safe drinking water? What is the environment like? So when we start talking about why we're seeing this, it is a multifaceted issue with multifaceted parameters that cause what we are seeing. I could go on and on, but I'm just going to limit it.
I'm happy to pick up wherever I can, because Dr. Gaither just totally slayed that response, which means in popular culture speak that she did an awesome job. So Dr. Gaither, thank you for that entry point and your wonderful opening with that medical expertise that you hold. I appreciate sharing this space with you. I want to point out three foundational points for us to ruminate and synthesize here. Structural racism, Black women's long history of mistrust in human service systems, which I include here, health and healthcare, regardless of private pay insurance or when administered by Medicaid. I would say that even if a person has private pay insurance and has a physician that looks like them that is not operating through an ethic of empathy that really centers that patient's care, then some of those issues will still be consistent. And finally, the social determinants of health. I want to flip what that is today. So I want to engage these points further here. The through line again is structural racism. Dr. Gaither talked about that weathering effect, which is what happens, which is the language you might use or hear in layman's terms when we hear about toxic stress. Dr. Gaither just outlined what happens in our bodies when we are experiencing toxic stress, which is that fight or flight experience our bodies are having, which is meant to be an event or a situation. It is not meant for us to live over a life course from birth to death, our entire lives. We're seeing that Black birthing folks are experiencing that toxic stress by which the pregnancies that they have are actually exacerbating the preconditions that they come into this pregnancy with. So what I want to again engage here is the through line of structural racism that Black women have been used as capital throughout history to promote the growth of the medical practice and other fields as well, but we'll focus on medicine because that's how we're here. So the experimentation on Black women from the times of James Marion Sims, who's a so-called father of gynecology, to the disposability of Black women's bodies and reproductive lives since the United States emancipation of slavery are things we want to think about here. The eugenics movement deemed Black reproduction unfit, thus focusing on sterilizing Black birthing people, and then really hyper-targeted Black birthing people since that eugenics movement really took off around that 1880s Comstock law. We started seeing, or rather continue to see, eugenics through sterilization of Black birthing people up until about the last quarter of the 20th century. And I would even venture to say, even to the 21st century, with practices around coercion with birth control use. I'll say that all of my discussions and points are coming from studies and research that show that, as well as me having been a practitioner and doing family and reproductive health planning and hearing these narratives firsthand that also map on to some of the larger national and state narratives and qualitative, quantitative research that has been offered as well. So this is a reproductive justice issue. So RJ Squared, which is the organization I have co-founded and am also the executive director of as part of the reproductive justice movement, believe that maternal morbidity, mortality, and infant mortality are threats to public health. Dr. Sills read the part of my bio around what the social determinants of health are, so I'm not going to bother to go into that detail. But what I want to talk about is how we move beyond the social determinants of health and marry it with elucidating the framework from Jessica Roach, who is the founder and practitioner at Restoring Our Own Through Transformation, which is called Root LLC in Columbus, Ohio. Jessica observes through a reproductive justice lens that the social determinants of health model does not adequately capture the historical structural racism embedded in our social structure, which has perpetually resulted in racial inequities. Her analysis, which she calls the web of causation, invites us to think about the ways by which structural determinants of health are perpetually creating this experience of that toxic stress, that weathering, which then sets Black birthing people up for that epigenetic experience that causes us to be in constant survival mode, quite literally. So in this web of causation and looking at the structural determinants of health against web of causation, and mapping the social determinants of health on this whole web, we're looking at how racism, slavery, Jim Crow, redlining, incarceration, and access to food, to name a few things, are core nodes with concomitant or simultaneous effects on Black birthing people, which shape our maternal and infant health outcomes. And with that, I'll close. Thank you.
Thank you both so much. Great information, great information. So our next question is, if it is statistically shown that Black women are more likely to die during the childbirth than any other race, why is there not more being done to protect them from being discriminated against by medical professionals?
I think it boils down, in most cases, to the fact of value. Do you value the life of a Black woman? Because if you valued that person as a human being, you would act in a different manner. When you crystallize it, and in my opinion, I mean, it really boils down to that, the value that is placed on a human life that has melanin.
Thank you. To add on to what Dr. Gaither has just offered, definitely, I, in my professional opinion, observations, and research, am seeing that the issue, according to my view as a public health educator and foundation scholar, see that centering racial equity is something that we are not really doing as a sufficient longitudinal practice. So we're perpetually reproducing harm because we as a society practice a microwave style of behavior modification. That is, we think the one diversity training series is going to solve all our problems. We practice a belief that doulas will save us, right? That we latch on to these contrived panaceas instead of evidence-based comprehensive approaches that our data-rich resources confirm our best practices. So we know what the practice is, or what the practices should be. We have the data, we're data rich, but in terms of subscribing to and committing to a practice that is sustained and that is ongoingly revamped, and as it is a practice, ensuring that we are shifting or shape-shifting the way we approach our human service and care work based off of what the needs show us and what the evidence is showing us. It's not something that we have seen a lot of evidence of having successfully implemented for the long term. We are doing that work, don't get me wrong. But I'm saying we have not wholly practiced and adopted a value set demonstrating an applied praxis. So note, I'm saying applying the known theories to a new applied systematized way of being to our ethic of care. Things aren't changing because we have not seen a practice commitment to an anti-racist, Black women-centered approach to Black maternal mortality. And again, the work is happening, but I would say that we still have some opportunity to see what that longitudinal effect might be, because these things are up and coming and getting off the ground now, and also led by some of the thought partnership and intellectual capacity of Black women, public health professionals, researchers, scholars, and community folks who are giving some insights and narratives to how this work should be done on and for and by Black women as well.
I think that if reimbursement situations were predicated on outcomes, I think there might be more of an increased sensitivity as to how Black women, melanated women are treated. You tie that money in, I think that would be more of an incentive for people to basically act right.
Thank you. So now we will move to our second round of questions, and these questions will surround current actions to decrease the Black maternal mortality rate. So our first question is, are there any laws that were passed to protect Black women from racial bias as it pertains to medical care?
I can't say that there are any specific laws that have been passed. There are certainly legal repercussions with, medical malpractice suits, but to say that there are any specific laws to, as a punitive measure, I can say no. There have been the beginning of a lot of laws that have been put forth to address some of the social determinants of health, like some of the legislators, Senator Adams et al. Has put forth, the momnibus bill, which addresses specific things relegated to things that should be in place for Black moms: access to genetic testing, access to the ability to have transportation, access, there's certain things that, that are specifically addressed in that momnibus bill that would be helpful, addressing the need to expand Medicaid for that fourth trimester. And for those of you who don't know what the fourth trimester is, it is that period of birth. It is that period of time after birth. And it's at that period of time after birth that a lot of stuff happens for which your insurance, particularly if you're on Medicaid, stops a couple of days after you deliver. But there's still that fourth trimester where ugly things medically can happen, not only medically, but mentally as well. You've got your postpartum blues, depression, and psychosis, which can occur, during that period of time. So there is a bill, there is an awareness. I'm cognizant that there are senators and our Vice President, Kamala Harris is on board as far as addressing these issues from a legislative standpoint, not a punitive one, but one of benefit. So to say that I have seen any specific laws that, are punitive against, treating Black birthing people in a particular adverse manner, no, I have not seen that.
I'm feeling like this whole section is going to be Dr. Gaither's wheelhouse, but I will say that definitely very proud that Black Mamas Matter Alliance has spearheaded the development of the Black Maternal Health Momnibus, for which Dr. Alma Adams and also Congresswoman Lauren Underwood have been championing with Kamala Harris prior to Vice President Harris's term as vice president. So this is good stuff. I also am prompted by something that just kind of popped up that I was going to reference as well, which is, that expansion of Medicaid and what I talked about in the prior question with my response around how we are lacking a commitment to an applied praxis with respect to how we then do care. Is the Medicaid expansion is so critical for us, right? Just like Dr. Gaither said, but in talking to a dear friend and colleague, Sylvia Zapata, who is currently on the line now, which I'm very, very excited about. Sylvia is an anti-racist colleague and executive director for Student Action with Farm Workers. And in our discussion, she made a critical assertion about the trend in our promising equity victories, particularly the Medicaid expansion, which we champion and we support, but just thinking again that it is so important that we have clear protocols predicated on intentional anti-racist training and longitudinal coaching to access the Medicaid expansion opportunities that that patients can and may have. So we want to continue to emphasize that intentionality to prolong sustained care and how we then give support to patients and shape human service professionals who may be at a different space than potentially the clinical providers that are offering the direct service care. We know that all of us are coming into our areas of expertise with particular lenses that really need to be checked and consistently polished and chiseled for us to make sure that we're providing an anti-racist approach and patient-centered approach to the work and areas that we are offering provision. So I want to make a point about how oftentimes access to Medicaid expansion for those who need it is still possibly going to be fraught with subjective risk steeped in some hegemonic leanings produced by the structural racism that we've been talking about. So it's extremely important that we continue to have that praxis of care and not continue to compound stressors for birthing persons, especially as people who are the ones who have the power to determine eligibility, right? So our healthcare system, our human service systems are layered with all kinds of folks that are gatekeepers that can determine how folks get this access. I was going to say also, just to add on to what Dr. Gaither offered here around the current, the Momnibus and other legislative advocacy, that we also know that in the reproductive justice movement, we are operating from the Human Rights Declaration. And that's something that we are doing through World Health Organization and the like. And I would say that the United States is one of the only nations that is not operating from a human rights perspective, and considering that we are a large, wealthy country, and we are not centering our practices on that, is quite concerning. So I would say this is an opportunity for us to make sure that we are aligning our laws, the way we provide care, to that human rights framework. And with that, I'll.
Thank you. And I see Dr. Seals dropped a few links in the chat, so feel free to check those out. Our next question is, Black women's concerns are often dismissed or ignored by medical professionals. So what is the best course of action once you voice your concern and are dismissed?
It depends on what setting you're in. If you're in the hospital setting, you can always contact the hospital administrator if you feel that, you know, you are not getting the care that you need. Other than that, if it's in the office and you don't feel like you're listened to, you know, seek out another provider. You're not a tree. You don't have to stay there and deal with it. So.
I love that United Tree part. That was awesome. I would also say, and this is, again, like I said, this is definitely me deferring to Dr. Gaither as a medical practitioner here, but also as someone that has done public health education and supported birthing families that are preparing for newcomers to their families, as well as having in my previous post been the consultant for the perinatal health strategic plan for the State Division of Public Health. I also want to lift opportunities for folks who are here to examine one, birthequity.org. Dr. Stills just placed that in the chat, National Birth Equity Collaborative, as well as Black Mamas Matter Alliance's Black paper for supporting Black birthing persons. I want to lift that, as we know from I am not recalling this woman's first name, but Dr. Moore, who was able to record her experience in an emergency department on Facebook Live. This is the woman who was a medical doctor who also ended up dying because of some pulmonary complications, and she wasn't listened to. Why am I bringing that up in this space? Well, because the question that was just lifted was around what we could do in the event that we're not receiving that sufficient health care, or we have some concerns about how we're being cared for. We can be our own advocate, but when we are in a space where we are needing to be cared for, sometimes we cannot be our own advocate. So what I am suggesting here is for us to start considering, while we are well and healthy in the spaces that we are in this moment, if we're coming to this space well and healthy, conscious and clear, to think about, what is my plan in the event that I need care and I am unable to advocate for myself? Who are the people in my community that I can trust to share my health needs and support needs for support with? And how will I be able to share with them when I need that kind of support and care? So I'm thinking, just as we in maternal and child health tend to provide recommendations for persons who are preparing for birth, to have a birth plan, for example, I'm suggesting beyond the space of the maternal or perinatal, that child bearing years, that we think about having a care plan for people who may be in our community who are beyond those who live with us. I'm thinking about how doulas are supporting birthing folk, right? There's also a such thing as a death doula, folks who might be supporting folks who are transitioning to the afterlife. Nothing to do with childbearing. I'm referring to just folks who are supporting your care. So the same way in which we might use, leverage and hone in on the support and expertise of a doula during this childbearing years when we're expecting to give birth, or we might be grieving a loss, I'm saying that we should really, really consider having a care team that we can count on when we are needing that support, because we cannot expect to advocate for ourselves sometimes when those issues have happened, when someone is dismissed, is when they are absolutely in a situation where they cannot speak for themselves. So who are our backups, who we can call when we know that we may be coming up with a matter or need that extra support? So I'd say let's start planning now what that team is comprised of and who they are.
Most often, I don't think that women do a lot of background assessment of who their prenatal provider is going to be. I think that given the perinatal outcomes, I think that thought now has become paramount for you to do some of your research before you get pregnant. Some of the best ways to get a provider are to ask your family members, ask your girlfriends, who is there that you trust, that is good, that will take care of you. Another venue is to align yourself, as you stated, with other organizations like Black Mamas Matter, Birth Equity. Also, there's the National Medical Association. The National Medical Association is the largest community of Black physicians in the nation, and they have a website, www.nmanet.org. You can always contact them to find out what providers are in your area that can assist you with whatever medical issue you have, even if it's not obstetrical. That's always an option as well.
Thank you all. And yes, we dropped Ms. Susan Moore's name in the chat. And yes, Dr. Sills also dropped a link to that article. So our next question is, if you receive insufficient medical care and report to your physician, what can be done to confirm that your concerns are actually heard? Also, if you report to your physician and still don't receive the correct treatment, what is the next course of action?
I think it would be difficult for a layperson to really consider whether or not what they got was sufficient. However, your gut or your intuition will give you some idea as to, this doesn't sound right. Again, as I've said, if you feel that you are not getting the right care, simply seek another physician. You shouldn't have to stay with a provider who isn't listening and, isn't offering what you feel is needed. You seek another physician.
I stand by my last response and high five Dr. Gaither.
Thank you. So now we will move to our third round of questions. This is our last round. So first question is, what do you believe would be the best way to reduce the number of Black mothers that die due to complications related to childbirth?
Again, that's a multifaceted question. I think that, and I don't know how to say this politically correct, so I'll just say it. You need to have providers that actually know what they're doing. a lot of times what you see in some facilities, particularly when they're in facilities of color, are just warm bodies who can fill the position. These providers are not necessarily the best and the brightest. That can lead to some bad outcomes, because if you don't know, you can't recognize, and you don't know that you don't know. So that can portend to some bad outcomes. So that's a whole conversation that I have yet to hear a lot of in the media. That's the first thing. The second thing is you should have, piggybacking on that, knowing that the 4 things that really are going to take out women of color are hypertensive disorders, hemorrhage, infection, and cardiovascular issues. You really have to be attuned and to really know your patient. I pride myself on having a very close relationship with my patient. So if I've been seeing my patient all along and she says to me, you know what, my head is killing me, I just don't feel right, and my vision is blurred, I'm not going to say, oh, well, girl, you got a migraine. I'm going to look at you and know that, she doesn't really complain and she's not looking right. Let me take her over to labor and delivery so we can have an evaluation to make sure that everything is copacetic. As a maternal fetal medicine specialist, I have been taught to think of what is the worst case scenario and then work backwards. So you got a headache, do you have a stroke? Are you bleeding in your head? Do you have a tumor? Are you, is your blood pressure so high that your brain is swelling? That's called cerebral edema. What is it that we're doing? So I'm going on the worst case scenario first to make sure you don't have that. And then we can work with, okay, she just has a migraine. But first, I'm gonna make sure that you're not bleeding in your head or your brain isn't swelling. I'm gonna make sure that you are not, getting ready to have a preeclamptic seizure. I have been trained in a certain kind of way to think, and I also listen and look at my patient. She doesn't look right. So I think a lot of what we're seeing in regards to these outcomes has a lot to do with the level of education, the level of diagnostic technique that a particular physician has.
I am a major champion for the work of the North Carolina Division of Public Health, specifically in the maternal and child health areas of the work. The North Carolina Perinatal Health Strategic Plan actually serves a statewide guide to improve maternal and infant health outcomes. And I'm gonna go ahead and drop the link to the PDF right now so you all have access to it. Just did that in the chat. And so the plan was initially released in 2016, and the update was released fall 2022 for the 22 to 26 4-year timeframe. And so the plan actually is based off of the framework adapted from the 12-point plan to close the Black-White gap in birth outcomes, a life course approach developed by Dr. Michael Liu, Cottle, Chuck, Hogan, Jones, Wright, and others, Halpon. And the plan is actually based on a framework of which the Perinatal Health Strategic Plan that North Carolina, as a state division of public health, has adopted, addresses economic and social inequities, strengthening families and communities, and finally improving healthcare for all people of childbearing age. And the plan actually is spearheaded by the Perinatal Health Equity Collective, which is comprised of stakeholders across the state, which are inclusive of medical doctors and other health and healthcare practitioners, researchers, otherwise scholars, and other public health scholars, epidemiologists, data statisticians, et cetera. And so I raise that because in looking at the 3 goals of the plan, each goal has 4 critical points. And of those points, I will not name them all, include undoing racism, supporting working families, enhancing coordination and integration of family support services, and providing interconception care. But all of this is also supported by work groups that come from communities across the state. One of them is called Village to Village. I'm very happy to say that I was integral in developing Village to Village with folks across the state and spearheading some of the working elements of the collective. But I want to point out that we cannot do this alone. In some of the more detailed elements of the plan, once you dig deeper into the 32-page document, you'll note that one of the calls to action is to ensure that that we're closing education gaps. We're talking about K through 12, and what that means for that health and education nexus, where the preparation in your education, K through 12, has a lot of implications for how our life course might be experienced. And there's some implications there also for, if someone is birthing a baby that is preterm and we know that there are going to be some complications in that early life of that child, there's also some related implications that connect to how that child might experience education. So there's some specifics there that I don't want to go into too much detail on, but where I want to go here is thinking about how some of the education points are also around how providers are educated in their undergraduates, graduates, and then their areas of practice for medical school, nursing, and other spaces where they're getting that expertise. So that understanding of structural racism, and even understanding, for example, as I said earlier, the origins of particular fields like OBGYN and the practice on enslaved women are things that folks tend to not know when they're going into the field. Understanding why certain populations, such as Black birthing people, which is our focus of the day, may have a mistrust of the medical system, is because of generations of narratives and firsthand experiences of folks having bad relationships with the medical field, with health and healthcare, right? So I'm saying that these issues are not isolated, and understanding the why and how Black persons' bodies have been treated as objects and objectified since we have been in this part of the world is really important to understanding. One, also how our bodies adapt to the conditions that we are living in with respect to having poor food access, low quality access to economic opportunities, oftentimes because of the education that we may have, perceived ability to go beyond where we may be situated, the reality of that a perception being a part of what the experience really is. So I'm saying there's so many things present that I think providers really need to understand from the perspective of how the structure is established and perpetuated for us to start seeing some changes. So I really am thinking that a part of that is understanding, one, what the landscape is and who's doing the work in our states, whoever may be joining us from outside of the state of North Carolina, that there are frameworks that are available and that are being activated, and that we can grab onto that work and see what local communities across the state are doing to then carry out this work.
I think it starts when you start talking about providers and who's seeing the patients. I mean, there is a network that starts, or that should start in grade school, the pipeline to get providers who look like the patients that they're caring for into the system. And there are a lot of roadblocks along the way, a lot of institutionalized racism. To get into medical school, well, who's opening the door to get medical students in? Typically you will find that the people that are the gatekeepers at these institutions tend to choose those applicants who look like them. And this goes up the chain when we're talking about medical school, when we're talking about residency, when we're talking about, jobs in hospitals. It's a multifactorial issue that has so many levels that you just don't know. Well, you do know where to start, but it is a cumbersome undertaking, to say the least.
Thank you both. Our next question is, do you think that a majority of the childbirth-related deaths are a result of poor medical care due to racism, or do you think that there is a deeper issue that has yet to be discovered? And what I mean when I say this, are there medical issues that are specific to Black women that increase the risk of dying during the childbirth, or are they mostly just caused by medical professionals' lack of empathy or care for Black women?
I'd like to lead this one. I was going to say, if I can start and then give to Dr. Gaither. I was going to point to a 2021 mixed methods community engaged research study led by Black women public health scholar activists, to name a few. One of them actually is from UNC Greensboro, who received their doctorate in public health. Dr. Brittany Chambers led this study with Dr. Monica McLemore and others. And they did a mixed method study in which narratives from Black women who represented different stages of their reproductive lifespan, preconception, meaning before they started having children, persons who are pregnant, and people who are postpartum, meaning that they had already recently birthed a human being, specifically outlined their experiences within what I used before in the language of Jessica Roach, the web of causation. So these participants talked about their specific experiences and offered their narratives within the web of causation. And some of the things they lifted were things like Black families experiencing hyper-surveillance by law enforcement. They talked about, the experience, for example, of feeling like they are being mistreated. Like Dr. Gaither said earlier, they talked about having the feeling of something not being right and feeling like they were not getting what they needed just by the way their provider engaged them. And when I say provider, I also want to be very specific in noting that I'm referring to anybody who is doing medical examinations, who might be somebody who is a clinician who's not solely a medical doctor. I'm referring to a nurse practitioner, any provider in the clinical space. So I want to be very clear about that. I'm not specifically pointing out one particular role, but we're referring to folks who are providing that care in that clinical space. And these participants in this particular study, and I'm naming this study, but there are studies that show and have narratives from various people from across the country that say the same things. And these women talked about these experiences. I'll also add that as my research looks at the relationship between health and healthcare and education, the constant surveillance of Black girls' bodies and adultification bias on Black girls, that means projecting the Black women stereotypes, i.e. that a girl is too loud, that she's sassy, hypersexualizing and over-sexualizing a Black girl is a part of what happens in that adultification bias. So adults are putting these ideas about adult Black women on girls who might be as young as pre-K aged children. And those girls are more likely to be pushed out of schools. Georgetown Law did a study on this in 2017. There's also a book called Pushed Out: The Criminalization of Black Girls in Schools by Dr. Monique Morris. Now her last name is Koopson, so you might see her as Koopson. But I'm making a point to say that these are the areas within what we might call generally in public health as the social determinants of health that are amplified with the hyper surveillance and the hyper gaze on Black persons' bodies, Black families, that we're seeing in this web of causation that's causing some of these issues. I'm saying that these studies are showing that the type of care that Black women receive is a reflection of structural racism, which I venture to say is an invisible global epidemic we've been living with since modernity, right? Since the founding of this country and this Western hemisphere that had people, Native people, living on it, in it, and within it for millennia. So I think that in order for us to understand what's going on here and looking at the question that you asked, hearing that, I'm thinking that the type of insurance a Black woman has, it really doesn't necessarily matter when we look at the numbers, because women who are insured privately, receiving Medicaid, and are experiencing various socioeconomic statuses are still dying in childbirth and in that perinatal stage. So I do not think that really, when it comes down to the numbers and what our numbers look like in this society, that does not have a major role. We're looking at what the belief in what patients are saying about what they're experiencing is when it comes down to it. And it appears, according to the data and the narratives, that Black women aren't being believed at face value. Their humanness is being questioned, as far as I'm seeing this in the bigger picture.
Yeah, you know, I recently read a paper, and I can't think of the name of it right now, but one of the things that it pointed out was, you know, for nursing staff coming out and for medical students coming out, they still think that Black people have a higher pain tolerance. They still think that our skin is thicker, so we don't feel things, we don't experience things a lot. Anecdotally, just, you know, I've worked in affluent areas and I've worked in underserved areas. You know, Black patient comes in, they are ascribed certain characteristics or judgments that are placed. And it carries over into the kind of care that they receive. You know, for instance, prime example, a patient that has sickle cell anemia coming in a crisis, you know, that's a very painful clinical situation. And having physicians and nursing staff not wanting to give, you know, a patient of color adequate analgesia because they are, you know, drug-seeking behavior. Why would you ascribe that to somebody that you know has a disease that in crisis is exceedingly painful, you know? So just having these judgments and these views and this non-knowledgeable type mentality, it impacts outcomes.
Thank you both. And I believe you all touch bases on our next question, you know, just regarding the healthcare that they receive. So thank you so much. So we will actually move on to our last question, which is, what can we do at this time to lower the Black maternal mortality rate?
I think having conversations such as this and putting out information, options, other health care structures. You know, Black Mamas Matter has a lot of networks where they seek to set up different alternatives to prenatal care that don't necessarily involve the typical hierarchy, patriarchal, white male dominated type health systems. I think having doulas is helpful to navigate the healthcare system and to serve as advocates. I think that women who are in the preconceptual period seeking the assistance of friends and family members as to who they should go to. I think having information as to providers of color that would be great taking care of you via, looking at the NMA or calling them, getting who's who in your area. I think it's a number of these things, and being knowledgeable as to what your health is. If you have comorbidities in the preconceptual period, going and getting that assessed and optimized before you even get pregnant, because there's certain medical conditions that will automatically portend to poor outcomes if they're not adequately managed. I think it's a whole host of things, speaking and being vocal with your legislators to put forth bills and legislation to address these type of things, being savvy as to what your legislators are promoting health-wise for the community, and voting these people into positions of authority that can be of benefit, as opposed to somebody who is not going to do anything and will, pose a detriment. I think it's a whole multifaceted approach to a long-standing problem.
I will say that my response is twofold with some extra nuggets. So first, trust Black women. This is a statement and campaign from Sister Song Women of Color Reproductive Justice Collective. It's a simple yet poignant reminder that the people we hear, those of us that are engaging in this conversation on the panel itself, in this virtual space, are aiming to support through policy. All of us who are here, not in conversation immediately, but who joined us in this space, are here to support the outcomes of birthing people. And again, our topic discussion today are Black birthing people. We're doing that through policy. And we want to center those that we are aiming to uplift, support, and see the outcomes for. So centering Black women's knowledge about their lived experience, and ensuring that we are co-learning and not just researching a group, but we are learning from, right, with. And we are doing this to mitigate some of these current threats to because I'm a Black woman, our health. And so I'm specifically thinking about activating an authentic community engaged research approach, which is devoid of, as Dr. Gaither said, that kind of cis hetero patriarchy approach, which can really feel disconnected and is intended to be disconnected from those who are researched. I'm saying that it's important for us to situate ourselves in the communities that we are hoping to learn and support, so we can learn from them and again, be taught by them. And this means listening to Black women patients, community members who may not be persons of childbearing age, but are kin to these women, health and healthcare, that the health and healthcare field is serving. It also means recognizing that maternal and child's health has some dynamic public health centered anti-racist practitioners that are in practice. Look at Dr. Gaither, right? Who are centering Black mothers, who proclaim and practice Black Mamas Matter, right? Not just the organization that is doing phenomenal work, but are also just doing that in practice. Another person I think about who I think is just dynamic, who's a Black Mamas Matter Alliance kindred partner, RJ Warrior, is Dr. Karen Scott. And Dr. Karen Scott has developed the Prem OB scale, which is a trademark valid tool to characterize and quantify obstetric racism for use in perinatal improvement initiatives. I recommend you look up PREM-OB. Check out Dr. Karen Scott. Also note that on April 14th and 15th of this year, if you are in North Carolina, and if you're not, come join us, because I will be hanging out with the Black Pearl Society, which is putting on the inaugural Black Maternal Infant Health Conference, which is going to be in Greensboro, North Carolina. Dr. Karen Scott is going to be a keynote speaker coming to us from Tennessee as a keynote speaker during that weekend, as well as the mother of Shamani Gibson. And her name is, the mom of Shamani Gibson's name is Shawnee Benton Gibson. Shamani Gibson is another person who has recently died in the last several years of a maternal mortality. There is a film that centers Shamani Gibson and Amber Rose Isaac's story. They're both out of New York, which has astronomical maternal mortality rates, even compared to the national Black maternal mortality rate. And that film is called Aftershock. You can see it on Hulu. But I would encourage you all to check out this conference, Black Maternal Infant Health, which is being put on by Black Pearl Society on April 14th and 15th. And see what Dr. Karen Scott has to say, what Shawnee Benton Gibson has to say at that time. Follow the hashtag Black Women's Health Week, Black Maternal Health Week, BMHW23, or hashtag Black Maternal Health Week. This is going to be from April 11th through April 17th, which is the 6th annual campaign to bring awareness to Black maternal health, which was kicked off back in 2018 by the Black Mamas Matter Alliance. When you put in those hashtags, it allows you to see what's happening around the world, around the nation, and in your local community around Black Maternal Health Week. So I would say, again, the things that we want to do are considering that we need to listen to Black women intentionally, and also consider that there are things that are emerging. There are the studies and scales like the PREM-OB scale that are emerging from the works of our public health research, medical providers, scholars who are centering the voices and experiences of Black mothers, Black mamas, and ensuring that we are applying these narratives to outcomes that are hopeful to see some closing of these gaps. Thank you.
Thank you so much. So at this time, we will open up the floor for a Q&A. If you have any questions at this time, you may drop them in our chat box. Or you can feel free to raise your hand if you have any questions.
I dropped a question in the chat. What are your thoughts on doulas, on the program called Centering Pregnancy, on implicit bias training for healthcare professionals, or quality improvement initiatives? These are many of the approaches that are currently being taken to address disparities in maternal health. Are they working? Are there ones that you would recommend over others?
We have a doula program here at New York City Health and Hospitals Lincoln in the Bronx. We do have a centering program. Now, as far as implicit bias training for medical providers, do I think that that is helpful? I have mixed feelings about that. I think that for some people, when they have to go to it, it's something, yeah, we have to do. Do I think that it really sinks in and creates a nexus for change? I don't know about that yet. I can't say that I've really seen a difference, but certainly doulas and centering pregnancy initiatives do work. Quality improvement initiatives, I think they bring awareness to some of the issues at hand. I'll just leave it at that.
I would have to agree with Dr. Gaither regarding the implicit bias. Some colleagues of mine and I have talked about the use of the word implicit because it makes it seem as if we're allowing harm doers to get off the hook. We all come with implicit biases. Yes, that is true. But there has been a corporatization of a lot of our diversity initiatives that really, really create a soft serve to the participants who attend these trainings without going into a robust analysis around the historical underpinnings of how our society has been structured. We oftentimes also focus on the bookends. As I identify as an African American woman, definitely of the diaspora. And even if I were not, if I were someone who were an African American woman who did not consider myself to be of the diaspora beyond the United States, I'm saying that my family is from the United States and also from Suriname, Curacao, and Guyana. So with that said, I want to lift that it is important for us to understand an international framework for how our structure has been established, because it was not just U.S. slavery only in the U.S. South that has resulted in the health outcomes and the conditions and the perceptions of Black bodies across the world. Racism has been exported, and it's not just because of the Western Europeans that we call British people that came late in the slave trade that created all of this mess. That's not where it started, right? So I think that we need to go into a deeper discussion around the origins and how these ideas have become implicit in our consciousness, and how media plays a role, who we live with. If we do not have counter narratives or counter stories from the consistent feedback loop of negative stereotypes that we see of people who do not look like us, then we are going to continue to believe those images and those things that we see. And I'm pulling out a small back pocket thread around some scenarios that might occur because our experiences are broad. But I'm thinking that some of the diversity training that might be available, and I'm using the language of diversity training because it often feels like something you're checking off that's just talking about, here's the crayon box, here are all the colors, they're pretty, they're cool, except if they're broken or not, let's go to lunch. So it's there's not a robust understanding of how we hierarchize people and where that came from. And I think we need to go deeper. And I think that the longitudinal affinity groups, discussions for how we might apply an anti-racist practice and analysis to our work and beyond, in our core value set for how we live our lives, I think should be a part of how we engage and also monitor and evaluate the professionals that are in our spaces and in the field of work that we do individually and respectively. So I think that's important. The Racial Equity Institute, which is actually based out of Greensboro, North Carolina, and it's based here in Greensboro, which is where I live, but it serves beyond the state's borders and internationally when they are called, is a great space to start to understand what that anti-racist analysis is, by understanding what structural racism is, by understanding how racism is embedded in all of our systems and our structure. It is what Isabel Wilkerson calls a mud seal, right? Her book is a good book, but I would say go get you some anti-racist analysis to understand all of this. The book is a great supplement, but get the analysis. Also, there's the Groundwater Institute, which is affiliated with Racial Equity Institute, where if you can't do a full 2-day Racial Equity Institute training, which you need to do that, The Groundwater Institute makes the point of showing how all of these systems are connected with the undergirding through line of structural racism. And they do this by sharing data and showing how across systems, again, that through line is racism. So I would say that those are the places we want to start. I'm not saying go there and then stay there and don't do anything else. This is a practice. We are to continue to do the work and apply it to our day-to-day. Regarding doulas, doulas are important. What I said earlier about the notion that doulas are going to save us all and that being problematic is that, again, we tend in this society to have these microwave ideas, and I'm thinking like we press start, hope everything works out, and then that's it. Doulas cannot be the scapegoats for an entire system. Doulas are a group of support people that do phenomenal work. But what is also coming to pass that I'm observing is that oftentimes these big name medical or facilities, organizations, higher education, teaching hospitals and medical places are giving all of their Medicaid and or low socioeconomic status patients to doulas to support, and then they are not compensating doulas and giving doulas the kind of bridged collaborative support
Doesn't really spend
monetarily and otherwise. So I'm saying that doulas are phenomenal, but we can't think that we're going to dump all of our things onto doulas and then one, not compensate doulas, and then two, assume that if things go wrong, oh, the doulas had them, so let's talk to them. Hold on. We need to have an interactive continuity of care that is co-constitutive of the doula support as well as the providers that are in that space, any other care providers that are beyond the medical team for said patient or family or what have you. So I definitely affirm doulas, but I think we need to think beyond putting everything on doulas solely. We need to be thinking about having an integrated care plan for our patients. And regarding centering pregnancy, I wholeheartedly affirm centering. I think it should be done to fidelity. And I think that while centering is a model that I see is done and I understand centering, have studied the centering practice, is something that a lot of Indigenous communities throughout the world have been doing for ages. And so centering is an awesome way to do healthcare beyond that of birthing, laboring, delivery, and so birthing and preparing for that experience. But I also think we should consider what our midwives, our Black midwives and other birth workers are recommending in that space as well. Yesterday was the inaugural Black Midwifery Day. So I want to also lift up midwives as well in this space. Thank you.
We have 3 questions in the chat. Mary Beth Faust, do you want to come off mute and ask yours?
I do. Thank you, Stephen. I'll come to video too. I was eating earlier, so I was off video. And this one's posed for both of you, but Dr. Gaither, as you were talking, we have a pilot doula project, and Jasmine, thanks for sort of saying like they can't be a sole solution or answer. But we have found that it's really difficult to pair our doulas with these high-risk pregnancy clients because of the difference in care model and like time frame for potential induction and what that does with the doula schedule and all of those kinds of things. So just wondering if you might speak to some of that too, about how doulas might prep differently for care of those high-risk patients or clients, or how they can be better partners in the birthing room for those like maternal fetal doctors who are really thinking worst case scenario, because they're not trained that way. Does that make sense?
Well, our model here at Lincoln, for the most part, we have a program where when a patient comes in, if she's in low risk clinic, she is, automatically offered, do you want to have a doula? And then they have to sign up, and the doula meets them, and then they kind of mesh as to when their appointments are going to be, if there's going to be an induction, so it's a lot of interconnection, a lot of discussion. For the my high risk patients, I carefully select who would benefit most from doula services. So for instance, if I have a patient, that has a significant cardiac history and she's blind in one eye, I'm not going to have a doula for that type of patient. So I carefully select who will have a doula. If I feel that even if she does have a lot of high risk comorbidity and she doesn't have any family support, then I would, have a doula in place. But it's going to be a very interconnected, discussion. They're going to be present for, all of the appointments, so everybody's on the same page. So in my high risk clinic, I carefully select who's going to see. In the low risk clinic, everybody kind of gets that, and then we take it from there.
Thank you.
I think next up was Losa Suber.
Yes. Hi. So I'm just curious to know your thoughts on social workers and how we fit into just reducing the maternal mortality rate.
Well, in my practice, I have a perinatal social worker, and perinatal social workers are like gold, because they are hooked into the community and are able to address a lot of the social determinants of health and diminish a lot of the issues at hand. For instance, does the patient have insurance? A social worker can hook her up. Does she have transportation? A social worker can hook her up. Does she have access to food? Is she living in a food desert? And she needs to, have adequate food. We have a program here called Green Grocer Program, where we give patients coupons, and like right outside our hospital for like months at a time, you have green grocers. They have fresh vegetables and fruits and everything right outside the hospital, and the patients are able to go with our vouchers and get their adequate vegetables and so forth and so on. But my perinatal social worker, like I said, is gold. Can she hook a patient into mental health programs? Yes, you can do that. So I think it would be helpful for practices to have that type of person on board, not just a social worker, but a perinatal social worker. There is a difference. And do I think that they can reduce the maternal mortality rate? Yeah. I definitely see it here. And the thing is, a lot of healthcare facilities, when I talk to some of my friends outside of New York, they don't have the kind of setup that I think is really important to take care of high-risk patients. You don't have your financial counselors, you don't have your perinatal social worker, you don't have a geneticist, you don't have nutritionists, you don't have a diabetic educator, you don't have perinatal sonographers, you don't have a maternal fetal medicine specialist around. And you're taking care of patients that have really high risk issues, but yet you have none of this. And I just don't see how one can function and have good outcomes when you don't have anything in place that addresses everything that is needed. What can I say?
Talitha Batts has a question.
Yes, I had a quick question in reference to doulas that was touched upon earlier, I think, and it may kind of connect with what you're already saying, but it was mentioned earlier that there are other types of doulas. And so I was wondering if there are doulas for adults who are aging in place, specifically female adults that are aging in place. And if so, if you could drop some information in the chat or speak to it.
I actually just finished the message that I was typing to respond to your query. I have dropped a link to Omi Sade Bernie Scott's Black Girl's Guide to Surviving Menopause. Omi is awesome. I love Omi. Omi is based out of Durham, but Omi's works have been featured in many publications, including O Magazine, Vogue, etc., PBS Vox. Omi has some features on the state of things for the state of North Carolina's NPR affiliate at UNC Radio. But I say that, you know, she's based here in the state, but work expands the state. Why am I talking about Black Girls Guide to Surviving Menopause? Because Omi has talked extensively about, as we engage reproductive justice and the reproductive lifespan, we tend to not talk about folks who are going into menopause. And part of her discussions, her podcast, which is an awesome podcast, by the way, you might find an episode. If I can locate it, I'll try to drop it in here before we go, if I could locate it. She's had episodes and discussions around the importance of having served as a doula for end of life care for people who've been in her life, and how she's at a stage in her life where she's providing that homegoing experience for folks. Now, is this type of service support an area of expertise widely publicized and discussed, like birth doula and postpartum doula services? No, not really. So that's why I'm saying contact Omi on that site so you can see what her recommendations are. But just because something is not corporately discussed and popularized does not mean people aren't doing this, because people do this. There are people who are called death doulas who do death doula work. In fact, I've got to Google death doulas. I believe that's the name of the actual episode that was on. So yes, there are people who support end of life transition for folks who might be in hospice care. And then also the conversation around understanding that once we come out of our reproductive stage, there are still vulnerabilities that Black women have who are going through that perimenopausal or menopausal stage. We also don't talk about. Aging is not cute in our society, and all the things that come with aging are not discussed, but it's natural. We're all going through it. I'm in my 40s. I'm actually approaching a big birthday this year. And so I'm finding I'm coming to this, and I just saw an article the other day that talked about millennials becoming middle aged. I'm like, I'm an elder millennial. I'm not middle aged per se, but you know, aching knees and the things that are happening with, you know, my reproductive system doing all kind of random things are things we're going through. But what I'm saying is we don't talk about that. We also tend to not talk about Black women who are going through infertility issues. So there are a lot of things that are mainstream conversations, and that there are some outlier conversations that we're experiencing we don't talk enough about. I would definitely encourage you to visit Omi again at Black Girls Guide to Surviving Menopause for all of those discussions in which she talks quite poignantly about, and particularly about the service and what it means to be a death doula.
Thank you.
Heidi Majors with YWCA High Point is offering a groundwater training with the Racial Equity Institute. Heidi, did you want to mention anything about that?
Sure, yes. We are partnering with REI and doing a REI groundwater training next Friday, March the 24th. There are still some spaces open, as well as we do, our cost is $25, but we do have some scholarships. So feel free just to email me or register on that link, and we can get you there. You do not have to be a member on that registration link. There's a non-member registration at the bottom. So hope y'all will join us.
And Tessa, I believe you had a question about occupational therapy students.
She said that her mic is faulty, so she
Oh,
can't
yep.
speak.
Sorry. Her question, her statement was, I've lost it here. There it is. I'm an occupational therapy student and proposed creating a maternal health literacy toolkit for my capstone project. The purpose is to increase knowledge and promote self-advocacy. What are some important topics and pieces of information you believe I should include in this resource?
How to find a provider. How to find a doula. How to rank hospitals. What resources are available for lactation services. How to help with finding adequate insurance. You know, those are some of the basics.
Thank you, Dr. Gaither, for answering her question. Now, at this time, I do want to be precious of everyone's time. So if you do have any questions, after this session, myself, Dr. Sills, and our two speakers, we can drop our emails in the chat, and you can send us an email and we will answer your question to the best of our ability. I want to say thank you all for joining us today. And also thank you so much to our wonderful speakers, and thank you all for your great questions as well. And Dr. Sills will capture the links that were shared in the chat and send them to the list of attendees, along with a link to the recording of our session today. And I want to say thank you all again. And if you have any questions for us, feel free to email us. And I'm going to drop my email in the chat right now.
Thanks everybody for coming. We really appreciate your attendance at these webinars. We'll be having a few more things coming up shortly. Talitha, if you're still there, do you want to mention our upcoming town hall and its topic?
Sure. We'll be talking about policy advocacy and action on March the 22nd, and it is a virtual call. You can go to our website or any of our social media platforms, LinkedIn or Facebook, to find the registration link. We'll also be sending that out. And if it's okay with you, Dr. Sills, maybe I could use the registration list for this particular call, and I can send the link out and the information about it to all of you. So if you're interested in jumping on that call, we would be happy to see you. Thank you so much.
Thank you, Talitha. And yes, we'll make sure that you get that that distribution list. Thank you again to Dr. Gaither. Thank you, Jasmine, soon to be Dr. Jasmine Getro-Moore. We really appreciate your time, your insight, your energy, and your emotional work in this space. Thanks so much.
Thank you.
Thank you.
Bye-bye.
Bye.
Bye.